I'm a cardiologist in the United States. I trained in India, actually. I went to King George's Medical College in Lucknow, and I finished my medical training in India in 1993. So that was my MBBS course. And then I did a residency in India in internal medicine at King George's as well. And a few years later, I actually came to the US and did some training in medicine because you have to repeat your training. And then did a fellowship in cardiology and eventually in cardiac imaging, which is a subspecialty of general cardiology. And imaging for me consisted of training in cardiac MRI and cardiac CT. So that was another year. So I've been in independent practice for a number of years, and HCM is one of my areas of interest. So I see a fair number of patients, been taking care of them for a number of years. And that's one of the things that I do. I'm also involved in some research, education of medical students, of residents. We have a fellowship program. We train fellows to become cardiologists. So that's one of my interests as well. Basically dabble in the care of patients in the outpatient clinic. I also take care of patients in the ICU, and so on and so forth. And apart from reading echocardiograms and reading cardiac MRIs and cardiac CT scans. So this is well within my area of interest. So that's kind of what I do. I'm an associate professor of medicine at Case Western Reserve University, which is one of the top 25 medical schools in the United States. And I also am co-director of the associate director of the imaging lab at Metro Health, where my privileges are. It's a hospital in Cleveland. And I'm also a director of the MRI program at Metro Health. So we are busy. We do a lot of stuff here. Relative to India, the numbers are smaller. They're always smaller because things are done more slowly here, but they're done, I
More
guess,
thoroughly too, I guess.
yeah. It's a little bit more detailed. So it's a more systematic approach, I should say. Patients have appointments and they follow up at regular intervals and so forth. And there's no walk-ins in clinic. It doesn't work like that. You have to have a
You have to
certain
have
set.
a reason, right? Like,
Yeah. You have to have an appointment made. So medicine is different. I've also wanted to mention how the practice of medicine in India is different. And I don't know, it's probably changed quite a bit since I left. Is that in the US, it's mostly private insurance based. You can have insurance provided by the government called Medicare, which is for people above 65 who are retired, who worked for a number of years in the US, and for poor people who are on Medicaid. So as the word is self-explanatory in some way. Somebody's in the waiting room. Should I admit them? Satish Kumar.
yes, sir, yes, sir, please admit them. I have actually made you the host so that you can like
Yeah.
control everything and share the screen.
Okay. Yeah, that's what I figured. So, all right. So as more people will join, I'll keep letting them in, I guess. Anyway, so that's the structure of how the government does insurance in the US. It's basically government that administers the care. People have paid into the system through taxes throughout their life, and they're working, and then they kind of get the benefits back. For Medicaid, it's a plain simple aid, right? So just get paid by the government, or the government pays for your healthcare. This is for people that are very poor and don't have the ability to pay for themselves. And then there's the commercial insurance patients who are like, if you work for a company, the company pays for your health insurance. And the company buys like a group policy for a large number of patients. And if you are someone that happens to have hypertrophic cardiomyopathy, you will most likely be eligible to get treated for HCM by this drug. No matter what the cost, if you have the drug and the drug is approved by the FDA, which is the regulatory agency in the United States for medicines and for food, you basically will be covered.
So
You may have,
we have something like that corporate medical thing, but
okay,
there is a strong cap. Like most of the companies, they have like for regular medicines. In my
yeah,
company, the last company I worked, it was 30,000 rupees per year. So that's
yeah,
like very low compared to,
yeah. 30,000 doesn't cover anything.
yeah, it doesn't cover
Right.
anything. Yeah.
Yeah, it doesn't cover anything. Even in India, medicines are quite expensive now, right? So
Yeah.
it's if you have a disease like HCM, I think it's going to be, at least for now, I don't see how this Camzyos is going to be available anytime soon. It's going to take some time, but I've been surprised at the pace at which some of the medicines have become available in India recently, right? So my parents live in India, and they have some health issues. So when I go back, I tend to find the best medicine for them in India, which are sort of evidence based and have been studied extensively and have shown the most promise. And I've always been able to find the medicines for them. Some of them are very expensive, but they can afford it. They have insurance coverage through their employer. My parents are retired, so for them it's not a significant out-of-pocket cost. In fact, there's no out-of-pocket cost. So for them, it's not a problem. But that's not what the majority of Indians are, right? They don't have
True.
this kind of luxury of the employer paying for their medicines for the rest of their life. So I think that is probably going to be a challenge. But that's not the main reason why we are here. So yeah, please ask away your questions, and I'll be happy to answer them.
Okay, sir. So moving on to the next point, like before we get into the Camzyos thing, could you like introduce us to some of the HCM specific nomenclature, like
Yeah,
LVOT and LVEF things, which will be
yeah.
important when you're discussing the rest of things.
Absolutely. So the some of the terminology, it becomes a technical discussion. I don't want to make it too technical. So essentially, hypertrophic cardiomyopathy is classified into two different types. There's the obstructive type, and then there's the non-obstructive type. Okay. Hypertrophic cardiomyopathy also is known as HOCM in some cases. So it is hypertrophic obstructive cardiomyopathy. So about one third of all patients with hypertrophic cardiomyopathy are non-obstructive. So they will present with predominantly with congestive heart failure, dilated heart, or just absence of normal diastolic function. And I will explain that in a second. The obstructive hypertrophic cardiomyopathy is about one third, okay, at rest. So you have some degree of obstruction. And then in about one third of the patients, the obstruction is provoked by maneuvers or with exercise. So two thirds are technically obstructed, one thirds are obstructed at rest, one third are non-obstructed. And the definition of obstructive hypertrophic cardiomyopathy is obstruction of the left ventricular outflow tract. So the left ventricle is the main pumping chamber of the heart, okay? And when it pumps, what's supposed to happen is that the blood comes in through the mitral valve into the left ventricle from the left atrium. So the left atrium is pushing blood down, the mitral valve opens, comes down to the left ventricle, which receives the blood. And now the left ventricle is pumping the blood out, okay? So when the left ventricle is pumping the blood out, in normal individuals, there's no obstruction to flow except for the aortic valve, okay? So the aortic valve prevents the blood from coming back once it has been ejected into the aorta. So the valve closes. Once the blood has been ejected, it doesn't come back into the heart, okay? So I'm going to admit someone else here. Okay, so anyway, so that's the job of the aortic valve. In patients with hypertrophic obstructive cardiomyopathy, where the obstruction, excuse me, is at the left ventricular outflow tract level, what happens is that the septum, which is the part of the heart muscle that kind of divides the two chambers of the heart, to two bottom chambers, the left ventricle and the right ventricle, there's a bit of a bulge typically at the base. And that bulge kind of becomes more prominent when the ventricle starts to pump. And on top of that, the mitral valve starts to get moved forward. So there's an abnormality of the mitral valve as well, okay, in many of these patients with obstructive hypertrophic cardiomyopathy. So the mitral valve apparatus is inserted improperly. There's an anterior movement of the mitral valve apparatus. There may be some redundant cords, which are basically tendons that attach the mitral valve to the left ventricular musculature. And essentially, it leads to almost like a Venturi effect, okay? So what's happening is that the septum is moving in this direction, and the mitral valve, instead of moving away, is also moving in this direction. So you can imagine that the outflow tract becomes really narrowed. okay? And that's what obstructive hypertrophic cardiomyopathy is. The ventricle is really thickened, okay? Doesn't have to be thickened all the time. It may only be thickened at the septum in the base of the heart in a significant number of patients, but it can be thickened in other parts of the heart as well. But that's not what causes the obstruction. So that's obstructive hypertrophic cardiomyopathy. In patients with obstruction symptoms at rest, the classification is that the obstruction has to be more than 30 millimeters of mercury at rest. Okay, so it's measured by Doppler on echocardiography. So Doppler is the principle by which we measure flows in the heart. Okay, and it's Doppler principle was basically applied in astronomy by Christian Doppler, who was a physicist a long time ago, but it's been used in assessing hemodynamics in the heart. Okay. There you go. Got someone else coming in as well. So that's obstructive HCM basically, and non-obstructive. So in addition to this obstructive feature, the heart is thick, and by virtue of that, and the muscle fibers are kind of in a disarray. They're not laid down properly. These are not straight, normal heart muscle fibers. They're laid down in a chaotic fashion. It's a crisscross mishmash. And they're prone to ischemia. So in other words, there's so much muscle that the blood flow and the capillary growth is not in keeping with the amount of muscle that's out there, okay?
So ischemia is like this, I didn't understand the ischemia part.
Reduced blood flow. So what happens is that the blood to the heart muscle that comes through the coronary arteries, okay? And when the heart muscle is excessively thickened, what happens is that the capillary muscle, the capillary vessel growth does not keep up with the thickening of the heart muscle. Okay, so there's not enough blood supply to that part of the very thick heart muscle. So when you're doing something physical like vigorous activity, then the demand goes really high. Okay, so the demand for oxygen is significant, and when the demand is excessive and the supply is not enough, you can have small parts of the heart muscle that starts to die, okay? And that is one of the mechanisms by which scar can develop. I think Santosh is texting here.
I'll just ask him to like wait until the session.
Yeah, we'll have some kind of a discussion. So I'm just explaining the pathophysiology of obstructive HCM. And in about a third of patients they may not have an obstruction at rest, okay? They may have obstruction with...
so maybe can you give me the host, right? So that I can deal with these things.
Yeah, I don't have a problem with... Let's see how to make you the host. Hang on one second.
Santosh, if you can hear us, we'll keep the personal questions to the end of the session.
Yeah.
Yeah.
So we'll keep that at the end. So just listen to what I'm trying to say right now. Okay. So the muscle is thick, and it may not be causing obstruction at rest, but with exercise or with a procedure, a maneuver called Valsalva, it can lead to worsening obstruction. Okay. And that is picked up by echocardiography. Okay. And that's how we diagnose obstructive HCM. And that's the biggest problem. And if the obstruction continues for a long time, if you have an obstruction more than 50 millimeters of mercury, you have to start treating it, okay? Less than 50, so more than 50, you have to start treating. If you have symptoms, you have to start treating. So those are the two indications for treatment in obstructive hypertrophic cardiomyopathy. So if you have to remember any numbers, those are the numbers. For diagnosis, you need more than 30 millimeters of obstruction, okay? And for treatment, you either need symptoms or you need more than 50 millimeters of mercury obstruction with either Valsalva maneuver or with exercise. So we can potentially, put the patient on a treadmill and then do an echocardiogram with and without exercise. So you do an echocardiogram before, and then you post-exercise, right, when they've gone to the most exercise that they can perform, you get them off the treadmill and you take more pictures and you determine what the degree of obstruction with exercise is. And if it is more than 30, then you've just diagnosed them with obstructive HCM, okay? So symptoms in hypertrophic cardiomyopathy may not occur because of obstruction alone. It's in part related to obstruction, right? And patients with obstruction do the worst because they tend to develop congestive heart failure, because you can imagine the pressure inside the heart may be like 200, 300, right? Sometimes your blood pressure is only a reflection of your the pressure in the heart if there is no obstruction. So if your blood pressure is, say, 120, okay, over 80, and your obstruction is 90 millimeters of mercury, the pressure that's going on in the heart is 210, right? So if your heart is continuously exposed to a blood pressure of 210, it's going to eventually start failing.
True.
It cannot keep up with that for a long time. And that's why many patients whose HCM is not treated will end up developing congestive heart failure. The other thing that we sometimes notice is that since the muscle is very thick, the heart doesn't relax as well. Okay, so there's two functions that the heart performs. One is the pumping function, the other one is the relaxing function. Okay, so the pumping function is the most important function of the heart, mainly the left ventricle we are talking about. But the relaxing function is just as important because it has to relax, open up, and accommodate the blood that is coming into it. So if the muscle is really thickened, then the heart loses its ability to relax easily. Okay. So when the blood is coming into the left ventricle from the left atrium, which is the chamber right above the left ventricle, and it is not accommodating the blood easily, the left atrium blood is actually coming from the lungs. So the lungs start to get congested. Okay. So you develop symptoms of congestive heart failure. In other words, you will start to get short of breath when you exercise, because now the blood is backing up in the lungs. Okay. And it has no way of getting into the heart because the heart is not letting the blood inside. So that's another explanation for why patients develop symptoms with exercise. Even though they may not have obstructive symptoms, they can still be symptomatic. The third reason is really ischemia, which I just mentioned previously.
You just told me, yeah.
Yeah. So those are some of the things that develop in HCM patients. So it's a complex pathophysiology. The other things that can happen sometimes is they're abnormal papillary muscles, which are muscles that are in the ventricle. And these muscle bands can sometimes be inserted in the wrong place, and that can actually cause obstruction to flow, but that's not as common.
Okay.
So that's the pathophysiology of the LV outflow tract obstruction or the LVOT. I don't know if that was entirely clear, but hopefully it was relatively clear to you guys.
It was quite clear. So, and the second thing was like coming from the part where the blood flow, the heart hardens and the blood flow is not sufficient. So, can you please explain about LVEF as well? And then we'll have to take a break because the link is limited. I don't have a pro version of the Zoom, so I'll reconnect the link. Yeah.
No problem. So you'll send a second link after
Yeah,
that?
I'll have to send a second link. Yes.
Okay. So LVEF is the ejection fraction. Okay. So ejection fraction really is the amount of blood that leaves the heart relative to the amount of blood that comes into the heart. Okay. So blood's coming into the heart, say 150 milliliters is coming into the heart. Okay. And the heart is ejecting 110 milliliters of that, right? So 40 milliliters is staying behind. So your ejection fraction is the fraction of blood that exits the heart with every beat. So it's 110 divided by 150. Okay. So that would be about 71, 72%. I'm just doing quick math in my head. So, and that's a little higher than normal. Most patients with hypertrophic cardiomyopathy actually have a hyperdynamic heart. So in other words, they pump out way too much blood because the heart is really thick. Okay. So it works really vigorously and it pumps out like 75, 80% of the blood. But they're also limited in that the heart is so thick that the overall capacity of the heart is smaller. So the heart has to pump more blood with every beat to actually keep up with your needs. Okay. So the ejection fraction tends to be higher.
So in this regard, I'm a engineer. So if I see it like a pump, so it's the ejection fraction is the ratio of the output upon input. Am I right?
Yes, correct. Absolutely.
Okay.
That is correct.
So in this regard, so if the capacity is lessened because of thickening of the heart, in generally like the myectomy aims at reducing the gradient.
Yes.
But why do we not increase the capacity of the heart? Like, why don't we?
Yeah, so you can't really do that. It's very hard, right? So the only way to do that would be to cut the entire heart out, right? And
Okay.
it's, so, and that would not make a huge difference either. So what you can do is administer drugs that actually reduce the contractility of the heart and improve the relaxation of the heart, okay?
Okay. Okay.
So, and beta blockers like metoprolol that, Santosh was mentioning,
Mhm.
Seloken is really a beta blocker, right? It's metoprolol. And that class of drugs actually reduces the rate at which the heart fills, okay? So it reduces your heart rate, all right? So if your heart rate is about 80 at rest, okay, and Seloken or something like that, like diltiazem or metoprolol, beta blockers, calcium channel blockers, can reduce your heart rate to say 60 beats a minute. So if you did that, what you've actually done is that you're allowing the heart more time to fill, okay?
Mhm.
Because you have more time available to you now. Your heart rate is slower, so the heart has more time to relax. And when the heart has more time to relax, it actually, you let it fill a little bit more, okay?
Mhm. Mhm.
So the heart size can change with the heart rate, okay, to some extent. It is not as common in HCM because the heart is so thick that the ability to actually get bigger in size than what it normally would be is very, very limited, okay? If you're an athlete, your heart is actually enlarged because you pump fewer times a minute, right? So really well-trained athletes have heart rates in their 40s. So, but the heart gets enlarged, okay? So with every beat, they can pump like 120 milliliters of blood. So they're actually pumping more blood than you despite a lower heart rate because their
Okay.
heart is adapted and it's gotten bigger,
So its
okay?
capacity has increased. What you say?
Capacity gets much bigger, right?
Okay.
But HCM, you cannot exercise your heart to the point that it starts to get bigger because you have the sarcomeric protein abnormality, which prevents the heart from actually getting bigger. And actually, there's constant pressure on the heart to continue to get thicker. And that's what HCM does to you. The other thing to remember is that patients may actually develop atrial fibrillation, okay, which is the most common arrhythmia in patients with hypertrophic cardiomyopathy. So it's a rhythm problem and it develops in the top chamber of the heart on the left side, okay? So it's the chamber called the left atrium, which separates it is separated from the left ventricle by the mitral valve,
Okay.
okay? So the left atrium gets all the blood from the lungs, which is
Mhm.
oxygenated in the lungs, okay? And then it basically pumps the blood into the left ventricle, which goes across the mitral valve. So when the atrium is pumping blood into the ventricle, which is the main pumping chamber that sends blood everywhere through the aorta, the atrium has to do a lot of extra work and push really hard into the ventricle because the ventricle is thick and is not accommodating blood easily. You see? So the pressure in the atrium goes up, okay?
Mhm.
And when the pressure in the atrium goes up, it dilates,
Okay.
okay? And the atrium is thin walled. It doesn't have thick walls like the ventricle does. So it dilates much more easily. And when the atrium starts to dilate, it becomes prone to arrhythmias like atrial fibrillation, okay? So the
Okay.
atrium starts to go into this chaotic, fast, irregular beating. And guess what happens when you develop atrial fibrillation? You can actually develop blood clots in the left-sided upper chamber of the heart or the left atrium. And that can cause a stroke, okay?
Okay.
So
So,
if
sir,
there are
here one question I have is
yeah,
many people that I visited, many doctors that I visited, they generally
yeah,
ask for LVEF, and
yeah,
the impression that I get from them is that they are really concerned that the LVEF should not go down. Like a lot of them have even said that sometimes it goes down because of
yeah,
because of
yeah.
HOCM.
No, that's actually so okay, so that's partly true. Okay. So in late stage HCM, you don't want the EF to drop because that happens as I was explaining to you, because the patient's not been treated properly, right? So if you have constant obstruction, right? So if you're living with a ventricular pressure of say 210 millimeters of mercury for 10, 15 years, your ventricle starts to dilate and your ejection fraction starts to go down because you're now developing heart failure, right?
Mhm.
So that's what your doctors are talking about They're not necessarily talking about anything else, but it's a failure of proper treatment. So if you've been treated properly with beta blockers and calcium channel blockers and disopyramide, most of the times it should not happen. And if you're still symptomatic despite maximally tolerated therapy,
Mhm.
the surgical myectomy still remains class 1 indication for these patients, right? Because what has happened is that, with this new drug that, that's come in the market, everyone's gotten excited. And I think it's going to be a very, very good thing for our patients. But there are no head-to-head trials to compare it with surgical myectomy, right? So we don't have any studies to show that it works as well as surgical myectomy does. Okay.
Okay, sir.
So
Brief,
it
brief
may it
background.
may it
Yes,
may work as well as surgical myectomy, but we don't have any evidence to show that just yet.
but we may prolong the surgery, like as far as I
Oh,
understand.
absolutely. I mean, I think it will. I mean, if you ask my personal opinion, I think it'll be very, very helpful. But at this point, when we're talking about science, science doesn't believe in emotion, right?
True,
we
true,
have
true.
to we have to have data, and their data is not there.
Yes,
I have a feeling that it'll work. I have a feeling based upon the data that we have so far that in the future we will be able to avoid surgery in a significant number of people. And I think that's the big advantage of this medication, is that it actually works at the molecular mechanism level, right? So
yes.
it basically changes potentially even the structure of the heart, right? So I think that's why everyone is excited about it. I will be happy to answer any questions.
Sure, sir. So, first of all, let's take one from the chat, and then we'll go on our the recorded questions before. So, Mr. Ankan Mandal has asked, what are the long-term effects of beta blockers? If you could comment on that.
Yeah, so beta blockers really don't have any long-term effects, right? So the effects of beta blockers will dissipate after 5 half-lives, which is basically, at the most 8 or 10 half-lives, which is a few days. So it takes a few half-lives for medicine to accumulate in your body, typically about 5. And metoprolol's half-life is pretty short. So if you're using the extended version, which is what you should be using for this condition, which is the once a day version of metoprolol, it should be out of your system almost completely in 5 to 7 days.
On
Uh,
that note, a lot of doctors have like encouraged me to not use the extended version. I don't know why, but like again, there have been a lot of doctors in Dehradun itself, like where I live, who've been like they would like me to use the non-extended version 3 times rather than
yeah,
the extended.
so that doesn't make any sense in principle, right? Because what I tend to do is use the extended version because it gives you 24-hour symptom relief. You don't want a drug whose level
Fluctuating,
continues to
yeah.
fluctuate throughout the day, and your symptoms will continue to fluctuate. So in this condition, absolutely, you should use the 24-hour version. It's much more preferable over the short acting. And when you're using diltiazem or verapamil is long acting always. But diltiazem, it comes as a short acting, but it can be available. It is available as a longer acting version also. And I only prescribe the long acting version for these patients. When do we start? So there's a question by Satish Kumar. It's a very good question. When do we start screening kids? At the age of 12 for those who are gene positive in a parent. So I think what I would recommend is that you test your kids for the same gene as well. Okay. So it's called cascade testing. So if you are positive, if you're gene positive, okay, and um, and you know that it's a pathological gene, it cannot just be any gene. It has to be a disease causing gene. So you need really good genetic counseling. Okay. So you cannot just go to any commercial lab and say, well, I have this gene. There's typically right now, there's only about 11 genes that are really well known. Okay. In HCM. There are certain small subtypes of genes that run in certain families, which are known to be pathological. But in general, there's the big 11. Basically, beta myosin heavy chain group of genes are the ones that you'll most commonly see as being pathological. So you really need a high quality genetics person to actually evaluate. So if you know for certain that this is a pathological gene that you have, all of your blood relatives should get screened. It's called cascade testing. Okay. And we should also do is take a 3-generation family history. So essentially, you got to make sure that your parent or your grandparent did not have it. Okay. So that's part of the workup. And then if your children are gene positive, then you have to really follow them very, very closely. Okay. And starting at the age of 12, because the growth of the muscle in HCM is linked with hormonal development. Okay. Okay. So the good news is that if your children are gene negative, then the chances that they will develop HCM is very, very low. In fact, almost zero. Okay.
Okay.
But in patients that are gene negative
Mhm.
and have HCM, you cannot stop screening of the family members and children at any point. You have to keep screening them every 2 to 3 years until they're 15 or 16 years old, every 3 years until they're 18 years old, and every 5 years thereafter. Okay.
Okay.
And you have to continue screening until 40s and 50s, because I've seen patients develop HCM in their 40s and 50s also, but it becomes much less common.
Mhm.
Okay. So if you're going to develop hypertrophic cardiomyopathy, more than likely you would have features of that in your teenage years. Okay.
As a
There's a
matter of fact, I did not have. So I'm like, I don't know, maybe it's
yeah, you that's what I mean. So you have to you may not have symptoms. Did you have family history, Ankur?
no. So I'm like, no recorded family history as such. It was
Yeah.
only after I was diagnosed that we went back and checked my mom and dad. And
Yeah.
my dad, like my mom came out with the hypertrophy, but she has no symptoms.
Okay, yeah. So there's something going on in your family, obviously.
Yeah.
There's a very good question by Ankan Mondal. Can we from India take online appointment? Yeah, I mean, you can. I mean, it's a question of
I think we'll share your details and how to contact you with the secretary and all later on, maybe.
yeah, that's fine. That's not a problem. And then alcohol ablation versus septumectomy, absolutely. So that's a great question. So alcohol ablation is in the United States is typically done for people that are high risk, okay, for surgery. That's the biggest indication. So you have to remember that these are older people with comorbid conditions such as bad lungs, who cannot go under anesthesia for a long period of time to have that surgical myectomy done. You can, it's not as effective, okay, as a surgical myectomy is. The other issue is this failure rate is higher, right? So about 10% to 15% failure rate, even in the best centers. The failure rate of surgical myectomy is much lower, and the complications in a good surgical center, the mortality risk in a good surgical center should be less than 1%, okay? So it used to be up to 10% about 15 years ago. 20 years ago, surgical myectomy was not a low-risk surgery, but in good hands and in people that really know what they're doing, the myectomy risk should be very low. For young people like you, I mean, which is, and this is a disease of young people, the surgical risk is very low. The trouble with the alcohol ablation is that you need a really skilled interventionist who's doing this. You need an echo lab that knows what they're doing, okay? And that is not easy, okay? Because what they have to do is they do an angiogram and then they inject echo contrast into your septal perforator vessels to identify which perforator vessel is actually feeding the septum, which is the thickest part of your septum. And if it is determined for sure that you have a big size septal perforator that's actually feeding the septum, you inject alcohol into a small amount of alcohol into that septal vessel, and you're creating a heart attack, basically, right? And eventually, with time, what happens when there's a heart attack is the muscle starts to thin out, okay? And it basically relieves the obstruction that way. It can be pretty effective. It is not as effective in reducing gradients as myectomy is. The other risk with alcohol septal ablation is the need for a pacemaker, because you have pacemaker cells right there. Okay, it's called the His bundle, or the bundle, and then it divides into the left bundle branch and the right bundle branch further down. But that's where the main electrical conduction system of the heart is sitting. So if you end up infarcting that, you may end up with a pacemaker at the age of 25. And pacemakers at a young age are terrible for you. You don't want that because they can lead to heart failure and other complications. So there are issues that can happen. Yeah. So another question is, what are the chances of muscle regrowth? There are no chances of muscle regrowth. It just doesn't come back like that. If they've done a good job the first time round and gotten rid of the obstruction, the muscle should not grow back. So that's my understanding.
That is very relieving, to be honest. I'm like,
Yeah.
I've ever since a mectomy, I've been worried about it. But
It shouldn't grow back. If they did a good job, if they got rid of, a significant amount of the obstructive phenotype, then there should not be an issue with regrowth. That's not a concern.
but sir, we is still gene positive and like still we
Yes.
so but you're saying like that does not, it won't happen again. Like
No, the obstruction won't happen again. The symptoms won't happen again unless you have an aberrant papillary muscle that is causing some funny stuff, which was not. So septumectomy surgery is not straightforward. Sometimes you have to reposition the papillary muscle. Okay. And if you have that problem along with thick septum, then that is going to continue to cause you problems. And hopefully, and that's why this is not an easy surgery. And that's why not every surgeon knows how to do this. Okay. Because they have to do the papillary muscle thinning also and removing it and moving it and all that kind of stuff, which is very, very complicated.
Okay.
Yeah.
So, like, should I continue or do you want to switch to Camzyos or should we continue with the questions? Like, how would you like?
I think at this point, I can talk about Camzyos a little bit if you guys want me to do it now. So, it's a small molecule inhibitor of the beta myosin. So basically, there's an interaction between the various proteins in the heart muscle. Okay, so the actin binds to the myosin. Okay, and as they latch onto each other, they drag against each other, and it creates the contraction of the heart. So it gets between the actin and the myosin chains, and it prevents the interaction of those two muscles and reduces the force with which the heart contracts. Okay, that's what Camzyos or mavacamten does. And it has been shown in clinical trials to actually increase the amount of exercise that you can do.
Mm-hmm.
It has been shown to significantly reduce the amount of gradient in your heart. Okay. And it may reduce the risk of heart failure because in these patients, it has been shown to reduce BNP levels, which is a peptide that the body releases when the heart is stressed. Okay. So there are positive signals, and a significant number of people that are on this drug ended up not needing surgical myectomy in a 2-year follow-up. Okay. So that's what the data shows, is that it can prevent surgery at least for 2 years, and that's all the data we have, in about 70 to 80% of the patients that are taking this drug. Okay, so that's really promising. And these are patients that have been well treated with, say, beta blockers and calcium channel blockers and so forth, and even disopyramide. One quick thing about disopyramide, it's a very effective drug. So if your symptoms are not controlled on a beta blocker, then I think you need to find a center where somebody can actually put you on disopyramide. More side effects, but it's a very effective drug. Okay.
Yeah, I was on it and I can vouch for it. Like it feels like you've almost healed like 50% in 2-3 weeks. Yeah. But the side effects are like severe. Like I had all weird things going on.
Absolutely, dry mouth, blurred vision, all of that stuff. It's not an easy drug to take. It improves your HCM symptoms for sure, but it is, in the long term, it's very safe. So it is the side effects of disopyramide, I just mentioned, it has anticholinergic side effects. Okay, so anticholinergic, in simple words, means it prevents the autonomic functions of the heart, of the body, right? Like sweating, like salivation, basically lacrimation, which is tear glands and things like that. So it can give you a dry mouth. It can, speed up your heart a little. Yeah. So it does have significant side effects, but it is otherwise a fairly safe drug. It does decrease the squeeze function of the contractility or the left ventricular ejection fraction. That's how it works. Okay. So it's a negative inotrope. when I say a negative inotrope, it reduces the force with which the heart contracts. And that's what you want. And that's what mavacamten also does. Okay. It reduces the force with which the heart squeezes. And with mavacamten, for example, there are some, in a small number of cases, it can reduce the heart function to a very large extent. So you have to keep monitoring the heart very, very closely with echocardiograms. And that's where the ejection fraction becomes important. So when it gets approved in India, I think very few people really should be prescribing it, because you have to do an echo, like every time you either change the dose or you increase the dose, or, so the patient develops new symptoms. So, at baseline, you do an echocardiogram, you get the ejection fraction, and then you don't change the dose for a few weeks. And then you go back and, you feel like the patient's doing okay, you do another echo, and the ejection fraction has not declined, you go up on the dose slightly from 2.5 to 5 milligrams, depending upon whatever the patient, how the patient's doing and what the degree of obstruction may be. Then you bring them back for another echo in 6 weeks, and you keep doing that until you're absolutely certain that the patient's heart squeeze or ejection fraction has actually remained stable. So, I have not started using it just yet, but, I know how to use it because I've been shown how to use it. Okay, I don't remember all the steps. It's not straightforward, it's slightly complex. So if you ask me all the steps on how to use it, I cannot describe it to you off the top of my head. I'll have to look into it. But, this is something that we are all going to learn with time, okay? So that's as far as Camzyos is concerned. I think of all the drugs that are on the market, it's the most promising. And I definitely hope that it becomes available to patients in India. But again,
so two questions in this regard. So
yeah.
What is BMS looking for when, like, once since you have decent information about BMS, how they work and all. So what are they looking when they expand into new markets? And what can we as a group do so that we can attract them earlier into India?
What you should do is find the BMS office in India. There has to be a BMS office in India. I would strongly urge that you contact their corporates and media relations people, okay? And you talk to the local CEO and say there's a very strong demand for this drug here, okay? So what a lot of times what US and foreign drug companies do is they partner with local drug companies in India, and they start marketing these drugs in markets like India, which is like a huge amount of people, right? So, the prevalence of HCM is anywhere from 1 in 200 to 1 in 500, no matter where you go. And in India, there's no reason to believe it's going to be any less than that. And of the 1 in 200 to 1 in 500 people, about a fifth or about a tenth of people are symptomatic, right? So you're looking at potentially millions of people with symptomatic hypertrophic cardiomyopathy. So, it's a huge market for them. They understand that the Indian patient cannot shell out $90,000 a year. So they may end up partnering with an Indian company to make the drug at a lower price. And that's something that you really need to, I think if patients really make the case, then they might start looking at you, because they might not even be thinking about India as a market, So you have to make them aware that there's a big pent-up demand here, and they will stand to benefit from this. So there's a new link, it looks like.
Just for later on, like he's just giving it for later on, like not right now.
Yeah. Okay. So that's that. As far as those, so that's all I can tell you about Camzyos. I don't have any insider information because I don't work for BMS. I just speak for them.
No, sir, I just asked what I thought would be like relevant in this.
Yeah, absolutely. It is relevant, definitely. Yeah.
So one more thing is that regarding this Camzyos. So does it, if we start using it, this is again an academic question, if we start using it early, so do you see it promoting favorable structural changes or delaying the onset of obstruction or anything?
That's a fantastic question. I think I never thought about that before. So since you're a patient, you can think about more things, obviously. No, I'm serious, right? So, well, if you start treating it early, like in pediatrics, for example, right, you're talking about using it in like a 15-year-old, right? Potentially where the phenotype is just starting to change. And I say phenotype is what the heart looks like, Okay.
Okay. Okay.
Genotype is what your genetics are. Phenotype is the actual structure, which may
Okay.
be completely disconnected. So you may have a gene positive case where there's no manifestation whatsoever.
Mhm.
Okay. So it turns out again that we don't have any data to show that it has a durable effect or it prevents the development of hypertrophy in
Okay.
people. Like, for example, a 15-year-old may have a septum of, say, 22 millimeters,
Mhm.
and they're destined to have a septum of 35, okay, at
Yep.
the age of 35, right? So
Yep.
because
Yep.
it continues to change with time, there's no data to show that it prevents further thickening of the septum, although I would imagine that it would do that. You know, I can imagine how it may prevent the heart from getting to its
As you
genetically
stop.
predetermined level of thickness. Yeah, it's certainly
Mhm.
possible. But again, no data. That's a fantastic question. I think there's a question in the chat by Ankan. It
Yes.
says my IVS was 32, which is interventricular septum, 32 millimeters before surgery, but was reduced to 15. But my EF stayed constant. Is that something normal? Yeah. So the EF has nothing to do with that, right? So the ejection fraction. So the bottom line is that if you're feeling better, right,
Mhm.
and your symptoms are relieved, you are in good shape. It's hard for me to imagine, though, Ankan, that your EF was only 55% before the surgery. I'm imagining that it was probably higher. Okay.
Also, I think a lot of people have EF around 55 and 60%, because even I had like 57% around
Are
before
people
surgery.
measuring it properly? That's my question to you, right? Is it being visually estimated or is it being measured diligently in the lab, right? So I can tell you that when I read a hypertrophic cardiomyopathy echo, our echo sometimes has 150 pictures.
Okay. Okay.
Okay, so it's not like a 30 uh, or 20 clips.
Yep.
Our sonographers will spend a full hour doing the echo. I don't do the echoes myself. We have
Okay.
trained personnel.
So we
Yeah.
have like 20-minute echoes, like the maximum I've been
No,
doing.
no, no. For HCM, it can take a solid 1 hour. Okay,
Yeah. Yeah. Okay.
to do an echo, and then it takes me sometimes 20 minutes to read the echo.
Okay.
Okay,
Okay. So that is
so
not
I'm
happening. Yeah.
I'm actually tracing the heart border. I'm actually calculating the volumes in more than one plane. So I
Mhm.
can tell you it's very unusual to see an ejection fraction of 55% in a hypertrophic obstructive patient. It's usually much higher than that. So I'm not willing to buy that the EF is accurate. So someone named Mr. Bhavnani is asking, can it be useful for non-obstructive HCM with 55 EF? What can it be
I think
useful?
he's talking about Camzyos, I guess.
Yeah, we don't know. So there's actually a study in non-obstructive HCM, which is a smaller study that was done, and it had some beneficial effects on VO2 max, which is the amount of exercise, the oxygen that you use during exercise. Okay,
Mhm.
and there was some beneficial effect on BNP, which is the brain natriuretic peptide levels, but there was no significant other improvements. So the treatment of non-obstructive HCM at this point is really just symptomatic.
Okay.
Okay. Yeah. So it's not as big of a problem as obstructive HCM is.
Okay. So I guess. So I'm like, but you do not have any, like, can you give, there is no drug in pipeline that you're aware of for non-obstructive people? Are you like aware of anything?
No, I'm not. I don't think there is any.
Okay.
In the pipeline, there's something very similar to mavacamten, okay, that is in development, but it's going to be essentially the same as mavacamten.
Okay.
Yeah.
I'm like, are you talking about the Embryo drug or?
I forget the name of it exactly. Let me just see. Uh, okay. Satish is asking a question about aberrant muscle bundles and in myectomy. Okay. So I'm not a surgeon. I cannot tell you all the details. Let me just see. I'm just quickly doing a search. Yeah, I forget the name of the drug that is in in clinical trials right now. Okay, forget the name of it, but it's not important. It's going to be very similar to Camzyos. Basically, it won't be that different. So the aberrant muscle bundle, again, is not common in HCM patients. Basically, what happens is that the papillary muscle, which is the muscle that attaches the ventricular muscle to the valve, tends to have a muscular structure to about 50% of its length, and the rest of it is like a thin tendinous cord that attaches to the valve. In some cases, what happens is that the muscle bundle continues all the way up to the valve apparatus, okay? So the muscle actually, instead of stopping midway through and converting into a tendon, continues all the way to the outflow tract. So it's thick, muscle is thick, cord is really thin. A cord is like 1 or 2 millimeters across in thickness, and a muscle can be like, half a centimeter or 7 millimeters in thickness. And when you're talking about a small space in the left ventricular outflow tract, okay, which is like maybe the square area of the circular area of the LV outflow tract is say 24 millimeters squared, and you're suddenly putting in another 10 millimeters squared in there, you basically narrowed it down further from 25 to say 15, which may not be enough. So that's the problem that the aberrant muscle bundle creates. So the job of the surgeon is to make sure that they actually get rid of that, okay? So they should be aware of that. They get rid of that, and they should also know that if they actually are getting rid of that, they have to transfer the tendon to a different papillary muscle.
Okay.
So that if you remove tendons from the valve, you're actually making the valve loose, right? Now the valve's going to start leaking. Now the mitral valve's going to start leaking. So their job is to make sure that the tendon that is attached to that papillary muscle now finds a new home.
Okay.
Okay. And it attaches to a different papillary muscle. And the idea, sometimes what they have to also do is to fix the valve itself, because the valve may be a problem. In addition, the mitral valve may be a problem in addition to the muscle itself. So the surgeon has to realize that, there are two problems here. It is not just the septum. There may be an aberrant papillary muscle. Okay, so that's why MRI is needed for everyone. Anyone that has hypertrophic cardiomyopathy and is going for a septal myectomy, you need a cardiac MRI, okay, to make sure that people, the surgeon needs to look at it, okay? There's another, this is a great question by Ankan about lifestyle. Vigorous activity like singles tennis, okay, and really high stress activity like marathon running.
So could you repeat? You said singles tennis?
Singles tennis.
Tennis. Okay.
Tennis.
Yeah, I get it.
Lawn tennis, yeah.
I get it.
Yeah, singles tennis, not table tennis, tennis, right?
Yeah.
Which is, really vigorous activity, if you're playing at a very high level, can increase your risk of sudden death, okay? But if you're doing a small jog, like if you're not going out running at 8 miles an hour, which is about 12 kilometers an hour pace, if you're going out running at say 4 miles an hour or 5 miles an hour, which is about 7-8 kilometers an hour, that is not a problem, okay? That is not a problem.
So in this regard, like, so sometimes we don't have a high gradient, but we experience a lot of symptoms. So is it okay to push through the symptoms, or like
no,
what would you recommend?
No, it's not. It's actually then recommended that you ask for more treatment. You talk to your doctor and you say, you're getting really symptomatic at that level, and you say, well, I probably need to up my dose of metoprolol, or I need to add a second agent like verapamil. So, the idea behind treatment is to help your symptoms, or maybe think about disopyramide, right? Because you want to be able to do that physical activity. You want to enjoy your life, right? You don't want to be restricted. So the risk of exercise is present in people who really go for it, like really hard, right? Like well-trained athletes. So there's the risk of sudden death. The other thing I would also remind you is that if your septum was that thick at 32 millimeters, then you're at risk of sudden death, okay? So that's one of the criteria for putting in a defibrillator, right? So whether septal myectomy changes that risk of sudden cardiac death because it has thinned your septum down is not clear. So um, all the data point to the fact that septal myectomy does not significantly change your risk of sudden death. Okay. So if you have other risk factors that can increase your risk of sudden death, such as demonstrated ventricular tachycardia, which is rapid episodes, more than one episode happening at a fast rate when you're doing a Holter monitor, then that's one significant risk factor. If you have a family member that has clearly died of HCM suddenly before the age of 50, you are at risk, okay? If you have apical hypertrophic cardiomyopathy with an aneurysm, that is a high risk of sudden death. You should think about a defibrillator. If your septum is more than 30 millimeters, then you're at high risk of sudden death and you should think about a defibrillator. If you have congestive heart failure and your ventricle dilates, so those are the 5 big ones that you have to remember for the risk of sudden death. And that's according to the new guidelines that just came out in 2020. They remove some of the stuff from the guidelines and they put some new stuff. So you usually feel heavy. So after you, is that, so having, so having.
So by the way, so this will be the last question before we switch to the next thing. So
yeah, no problem.
Yeah.
So Ankan is asking whether it's very common to feel palpitations after having food. Is that something very, very common actually? That's a very well-known and well-described symptom in HCM. Of developing symptoms after. So my recommendation to patients that have that is to actually eat small frequent meals instead of having the typical 2 to 3 large meals a day, okay? So don't eat a large amount of food at any point of time. That is telling you that the heart is, so when you eat food, things start to vasodilate, okay? And vasodilation is the vessels start to relax, and that actually drops your blood pressure. And when that happens, the degree of obstruction in your heart starts to go up, okay? And that actually creates a problem. Yeah, and postprandial gradient is one way of looking at symptomatology, and it's very, very common. So I think that's an indicator for increasing your beta blocker dose or calcium channel blocker dose or adding disopyramide or having small frequent meals. That's my recommendation to most of my patients that have that symptom.
So, sir, like this is primarily food thing is primarily related to lifestyle. Like you won't recommend any medication or anything, or any other thing. Like
well, that means that your obstruction comes on easily, and then you have to think about a higher dose if you can tolerate it. Many young people already have a low heart rate at rest. Okay, so they may not tolerate a lower dose. They may already be at a heart rate of 50. So what do you do then? Then you maybe switch them to disopyramide from metoprolol, right? So you stop the metoprolol, you bring them over to the hospital, or you start them on disopyramide. That's one way of dealing with it, okay? So that you're not slowing their heart down further, because adding disopyramide to metoprolol will actually give you a slower heart. They will not rely on the testing that was done in India, okay? They will repeat the echo. They might repeat the MRI. If you have not had an MRI, they will do an MRI. And you'll need to have a champion, cardiologist, say at the Cleveland Clinic. You can speak with other people also who may be able to make a case for you to get the surgery done, but it's going to be complicated, but something like this can be created. But I cannot, I can get in touch with them, but I don't know if they will be willing to do a whole large number of patients for charity. They'll probably do some, but again, I cannot speak for them. It's the business model is different.
And I guess flying them here, like the idea, do you think it is possible?
Yeah, that's possible. What they could potentially, like, I think it would be like a workshop, but it'll have to be organized by a big healthcare system in India, right? Say Apollo brings Dr. Smedira, right? And Dr. Smedira comes to India for like 10 days and he operates on 10 people or 20 people and then he goes back.
Okay.
Right. So that can be done. That can be done, but and that's a much better option than patients coming from India all the way to the US. That makes no sense, right?
Okay.
So he would, at the most he can do maybe 1 or 2 surgeries a day. I mean, these are complicated surgeries.
True, sir, true.
And he would have to take maybe 20 days off from his work schedule at the Cleveland Clinic, for example. And that's not easy. And he's not the only one. There are many others that we can find but something like this, I think how that would help, I think, is it would train surgeons in India,
Yeah,
right?
that could
So
also help.
because they'll be in the OR with them, and in the operating room, they will learn how this is done, and they will see all kinds of complicated patients. And actually, it may help some of the cardiothoracic surgical fellows to travel with, say, Dr. Smadira, okay,
Okay.
and who are training at the Cleveland Clinic, and some of them are from India. So they may actually be able to learn, because they don't do that many surgeries for septal myectomy in the US. I mean, the population is smaller, right?
Mhm.
And the number of surgeons is high. The
Mhm.
number of surgeons that do the surgery is relatively high. So it may be actually a good thing for Indian surgeons to get exposed to his expertise in some ways. And he can train others in India. He can train the cardiothoracic fellows in India. He can train cardiothoracic fellows in the US, who probably will never get to see maybe 20 surgeries in 20 days, you know?
Okay. Yeah, yeah. So
So you can make that work. I think that'd be terrific. And I can act as a liaison. I can talk to them, but I think the big healthcare system, potentially could, if they reach out to me, I can actually help them connect with the surgeon here, and maybe they can come up with something interesting.
I'll see. So I'll talk to a few of them. I've talked to one or two. I talked to a place in Bangalore which was doing my surgery, but they were
Yeah,
more into volume. They didn't want to get into any niche surgery. So it was very
yeah.
difficult to convince them to go for like an advanced set of surgical techniques or anything.
Well, you would have to make a business model case for them, right? So you
Okay.
have to convince them that this is the prevalence of the disease,
Mhm.
and these many people are affected,
Mhm.
and this is the potential market growth for you. So
Okay.
if they see the market growth in that and say, well, we can probably make this a significant part of their business model, then they might be interested in something like that. You know what I mean? You have to
Yeah.
convince them that there's a large number of patients that actually need this kind of care.
Mhm. Mhm.
You know?
That makes
Yeah,
sense. That makes sense. And
yeah,
so again, about this thing, like I heard that there are satellite centers of major U.S. hospitals in the Middle East, the
yeah,
Abu Dhabi and Dubai.
yeah,
So
yeah.
is it possible to get the same level of care there as in the U.S.?
Probably not. I would doubt it, because the Cleveland Clinic has its center in Abu Dhabi. I'm not sure about all the details. It may be worth checking with the Abu Dhabi center as to whether or not they do this. If they do it, that's wonderful, but I doubt that they do everything that is done here at the main campus.
Okay. Okay.
Yeah. They have a center in London. I believe they have they have a center in Florida, but I don't believe that they are doing all the most complicated surgeries. Maybe they are in the Middle East. It's quite possible. I'm not sure. I haven't looked into that.
But most likely Dr. Smadira is not there. Like I understand.
No, no, he's not. I'm sure he may have gone there to train some of the people there if they're doing the surgery. It's possible that he trained some of the folks that are actually operating out in Abu Dhabi. It's possible. I think it's worth looking into. It may be the case. Yeah.
Okay. So and one more thing, like I think one guy asked, is it like what would be the right correct way to get online appointment with people, like with of course you and people at Cleveland Clinic, like or even online consultation would be like, beneficial to us.
They have a second opinion line that you can use. If you just call their department of cardiology, and or you just go on their website, there's a second, if you can just go to the website and say a second opinion Cleveland Clinic, you should be able to find something. I haven't personally looked into that.
Okay, sir. Okay. So I'm like, you don't really like you don't get many patients from India who like go for online consultation and like this.
No, not that I know of. No, I haven't. It hasn't happened before, but I'm happy to help in any way. Satish is asking a question about, does Camzyos help with mid-cavitary obstruction? I'm sure it does. It just has not been studied in that group, right? So it's going to reduce the contractility of the heart, right? So if most of your obstruction is at the mid-cavitary level and you're developing an apical aneurysm, then I'm pretty certain that it would help in those patients. But I think there's no data. So literally you would have to just use it and find out, right? So you would have to get careful echoes to make sure that the rest of the heart is not dilating and you don't develop congestive heart failure. So that's a great question, but I don't think that I can tell you conclusively that this actually is approved. Once the drug comes out, people will use it for that indication, I can guarantee you, but that's a smaller segment of hypertrophic obstructive cardiomyopathy.
Okay, so I think I've exhausted most of my questions. If the people here have any more questions, do shoot.
You're very welcome. Yeah, absolutely.
And so I think you already answered, but we can't take a US insurance, right? Would that work if you take an international insurance for the US?
No.
Private insurance?
No, you can come and get travel insurance, but travel insurance only covers previously unknown conditions, right? It doesn't cover previously known conditions.
Okay.
So you come here, you develop like a new cough, or you develop a pneumonia, or you develop COVID, they can get coverage for that. But if you come here with the notion of getting operated on a traveler's insurance for HCM, absolutely, they will not cover you.
Okay.
Yeah.
Good to know, I guess.
Yeah.
Suppose we have a specific number of people in a group, like we are still only 20 people, but as we grow, if suppose we reach 1,000 people, like, do you think we can negotiate a deal with Cleveland Clinic or?
Yeah, you may be able to do that. Actually, then see, the thing is, there is strength in numbers, right?
Yes.
You may be able to do that, but they will not lower their price. I think what is much more realistic is to grow this as an organic movement, right? The surgeon comes down, he trains some of the surgeons in India, and then the Indian surgeons start to do it.
Okay.
And they become more confident because he's doing workshops for them, he's teaching them, but there has to be something in it for him also. He needs to be interested, right? So he's not going to spend 20 days of his life every year in India unless there's something there's an incentive for him to come down, right? So whether the incentive is financial or not, I mean, that's a different story, right? So the Indian hospital will have to, in some ways, say, well, I'm going to match your salary. In fact, I'm going to double your salary for the 1 month that you're here. And you come down and you operate, and we'll pay for your first class airfare back and forth. And the hospital then charges the people for the surgery. I mean, his 1 month salary is not going to be prohibitive. You know what I mean? He probably makes about $100 million a year. So, maybe $100,000 for 20 days. That's not a bad deal. That can be done. But you would have, I mean, and fame and reputation, and for the Cleveland Clinic, so the Cleveland Clinic then grows its tentacles in the US, in India, stuff like that. I think they have some partnership with some hospital in Bombay. Okay. But it's not like it's happening. I don't know how strong that partnership is at this point, but they do have some kind of an understanding with some hospital in Bombay. But again, I don't know the details. So you would have to look into that. And there are other institutions that would be willing to do this as well. I mean, it's not just the Cleveland Clinic. I mentioned the Cleveland Clinic because I live here and I know some of the people there.
Yes. Yeah. So it's a good thing to look at. I'm like, I didn't know that Cleveland Clinic was partnering with the Bombay hospital. I'll look into it and see.
It was a long time ago. I don't know if they still have a partnership, but I believe they did. One of the surgeons that trained at the Cleveland Clinic actually ran the surgical program in Bombay. Okay. And it might have been Dr. Panda, I think, Panda, if I'm not mistaken. He's a surgeon.
Okay.
Yeah. So you may want to look into that. So he may be your liaison. But again, that's something that nothing is impossible, right? If you have the right set of incentives, people will do stuff. You have to create the right set of incentives, right?
Yes, sir.
So yeah, I'm sure he'd be willing to come and teach folks here, provided he gets rewarded handsomely for it, right? It has to be something good for him also in the process.
True. Yeah. Perfect sense. So, sir, thank you for the whole session. And I don't think anybody else has any questions.
Yeah.
Hi, doctor. Thank you for your valuable time. This means a lot to us. Thank you.
Oh, you're very welcome. Take care. Have a good day, everyone.